Hello everyone, I am Dr. Trupti and this is my YouTube channel Enjoy Biochemistry. If you find the content on this channel useful, please like, share and subscribe. In the video lecture series on thyroid gland, in part 1 we have studied about synthesis, secretion and regulation of thyroid hormones. Then in the second part, mechanism of action and various functions of thyroid gland have been explained. In the third part, disorders associated with the thyroid gland like hypothyroidism, hyperthyroidism, their causes, clinical features, diagnosis and management was discussed in the brief, and this is the part 4 where we are going to learn about the thyroid function tests and their clinical significance, and we are also going to discuss some clinical cases related to hyperthyroidism and hypothyroidism. Thyroid function test, as the name suggests, these are various tests which are done to assess the functions of thyroid gland. And we know that thyroid gland affects almost all the organs of body and results in the condition like hyperthyroidism, where there is increased synthesis and secretion of thyroid hormones, and hypothyroidism, where there is low production of thyroid hormones. So these thyroid function tests, they are used to assess these conditions of hyperthyroidism and hypothyroidism and also find out the etiology behind these disorders of thyroid gland. What is the significance of thyroid function test? These function tests are used to diagnose the thyroid disorder in symptomatic person, screening of newborns for hypothyroidism, monitoring thyroid replacement therapy in hypothyroid patients, diagnosis and monitoring female infertility patients, and screening adults for thyroid disorders. So these are the various uses or significance of thyroid function test. Who is at risk for thyroid disease? So what are the various indications to do thyroid function test? So thyroid function test should be done in all newborn as a part of neonatal screening. If there is any personal or family history of thyroid disease, if there is the presence of autoimmune disease like in patients of type 1 diabetes mellitus, because most of the thyroid disorders, they are associated with autoimmune disease. Autoantibodies are generated, for example Hashimoto's disease, Graves' disease, all these are autoimmune disease. In conditions of Down syndrome, Turner syndrome, if there is history of neck irradiation, in that condition also thyroid function test should be done. If person is on the drugs like lithium, amiodarone, then those patients should be screened for thyroid function test. Elderly patients, pregnant women in the first trimester, in postpartum period, that is from 6 weeks to 6 months after delivery, and if the person's lipid profile is deranged in case of dyslipidemia, as we know that hypothyroidism is associated with hypercholesterolemia, hyperthyroidism is associated with low cholesterol level. So these are the various indications of doing thyroid function tests. Thyroid function tests are divided into 4 groups. Group 1 includes the estimation of blood levels of thyroid hormones. For example, serum TSH, total T3, T4, free T4, T3, reverse T3, protein bound iodine, thyroxine binding globulin, but most commonly serum TSH and free T4, T3 are estimated. Group 2 includes the thyroid function test to assess the primary function of thyroid, and these tests are radioactive iodine uptake or technetium-99 uptake thyroid scan, thyroid ultrasound scan, thyroid fine needle aspiration biopsy. Group 3 tests are immunological tests which are used to detect the antibodies, that is anti-TSH receptor antibody, anti-thyroid peroxidase antibody, anti-thyroglobulin antibody. And group 4 thyroid function tests are based on the assessment of metabolic effects. For example, BMR and estimation of serum level of cholesterol. Earlier, TRH stimulation test was also used to differentiate between primary and secondary conditions, but now new sensitive TSH assay has eliminated the necessity of performing TRH stimulation test. So this is not routinely done now. Now let's see the significance and interpretation of each group of thyroid function test. Group 1 includes estimation of blood levels of thyroid hormones, and serum TSH and free T3 T4 are most commonly group 1 tests which are done to assess the thyroid disorders. We know that thyroid gland produces T4 and T3, and 90% of T4 is secreted from the thyroid gland and 10% is T3. And the free form is 0.03% of T4 is in the free form, while 0.3% of T3 is in the free form. So this free form is metabolically active form, and these free thyroid hormone levels, they correlate more closely with the thyroid status of body, and that's why they are true determinants of thyroid function than the bound form. Now out of this T3 and T4, T4 is more relevant. Estimation of T4 is more relevant because 90% of the thyroid hormone released from thyroid gland is T4, and most of the T3 is formed from peripheral conversion of T4 to T3, and that's why estimation of free T4 is more relevant than estimation of free T3. The reference ranges depend on the method of analysis, and that's why results should be interpreted using the range from the laboratory that perform the test. And different thyroid function blood tests must be done on the same day, and they also need to be in the same units of measurement, as different methods have different units. Now what are the various methods which are used to estimate these blood levels of thyroid hormones? The first method is radioimmunoassay. Second, enzyme linked immunosorbent assay ELISA. Chemiluminescence immunoassay CLIA. Fluorescence immunoassay or electrochemiluminescence is also used. So these are the various methods of analysis of blood levels of TSH, free T3 and T4. Coming to the interpretation of group 1 test, and these tests include estimation of thyroid stimulating hormone, that is TSH, and free thyroxine, that is free T4. So the first interpretation is euthyroid state, where both TSH and T4, that is free T4, are normal. They are within the normal range. So TSH is normal and T4 is also normal. This is a euthyroid state. When TSH is high and free T4 is low. So when free T4 is low, this condition is hypothyroid. And here TSH is high. This is the primary hypothyroid condition, where the pathology lies itself in the thyroid gland. It is due to dysfunction of thyroid gland, and most common cause of primary hypothyroidism is Hashimoto's thyroiditis, iodine deficiency. So this is the primary hypothyroid condition, which is characterized by decreased level of free T4 and increased level of TSH. Now both, if free T4 and TSH, if they are decreased, it is called as secondary hypothyroidism, where the pathology lies either in the anterior pituitary or in the hypothalamus. So this is condition secondary hypothyroidism. It is characterized by decrease in level of both T4 as well as TSH. Subclinical hypothyroidism, it is characterized by high level of TSH and normal level of free T4. Then comes primary hyperthyroid. When it is primary hyperthyroid, when there is free T4 level but TSH level is low due to negative feedback mechanism, and it is due to dysfunction of thyroid gland itself, it is called as primary hyperthyroidism. Secondary hyperthyroidism, the T4 level is high and TSH level is also high. So secondary hyperthyroidism is characterized by increase in both TSH as well as free T4 level. Subclinical hyperthyroidism, it has normal free T4 and low TSH level. If the patient is on thyroxine or ultrauxin, that is the medication used to treat hypothyroidism, in this condition free T4 can be high but TSH will be normal. If TSH is normal and free T4 is low, then it is non-thyroidal illness. So this is the interpretation of group 1 tests, that is group 1 thyroid function tests. Group 2 thyroid function tests are done to detect the primary functions of thyroid, and they are radioactive iodine uptake thyroid scan, thyroid ultrasound scan, and thyroid fine needle aspiration biopsy. Radioactive iodine uptake and thyroid scan. It is used to assess the thyroid function by measuring iodine concentrating property and its uptake by thyroid gland after ingestion of radioactive iodine. So in this procedure, the radio tracer is either injected in the body or swallowed. So radioactive iodine is ingested, and most common tracers are iodine 123, iodine 131 or technetium 99. And these radio tracers then accumulated in the thyroid gland, and radioactive emissions from the radio tracers are then detected by thyroid scan using the spatial gamma camera. So after the ingestion, after 4 to 6 hours and 24 hours, with the help of gamma probe, radioactivity of thyroid gland is measured, and we get the pictures which provide us the information about thyroid precise size, shape, position, function and activity of nodule in relation to the rest of thyroid gland. So in normal condition we get such type of picture, that is the radioactive iodine uptake is normal, that is 15 to 25%. In case of Graves' disease, hot nodules can be seen, which is also called as autonomous nodules, which are always non-cancerous. Such kind of picture is found in toxic multinodular goiter, and this is toxic adenoma. What is cold nodule? Cold nodule take up less isotope and appear lighter, and it could be cancerous. And radioactive iodine uptake, it cannot differentiate between benign and cancerous lesion, and that's why biopsy is required for confirmation. Renal excretion of radioactive iodine is indirect evidence of thyroid function, which is inversely proportional to thyroid uptake. Thyroid ultrasound scan is common imaging test used to evaluate the structure of thyroid gland. So with the help of this thyroid USG, confirmation, characterization of thyroid nodule and evaluation of diffuse parenchymal changes can be done. It is used to detect the post-operative residual or recurrent tumor. It can differentiate benign from the malignant thyroid mass, and it is helpful to guide diagnostic, that is FNA cytology or FNA biopsy, and therapeutic interventional procedures. So these are the various uses of thyroid USG, but FNAC is required, which is a gold standard to differentiate between benign and malignant thyroid nodules. Group 3 thyroid function test includes immunological tests to detect autoimmune diseases where autoantibodies are developed. There are three types of autoantibodies. First antibody is against the thyrotropin receptor, that is TSH receptor. It is called as a TSH receptor antibody. It activates TSH receptor and increases the synthesis and secretion of thyroid hormones. These antibodies can be thyroid binding stimulating immunoglobulin, that is TSI, or also called as long acting thyroid stimulator, that is LATS. It can also be inhibitory immunoglobulin, that is thyroid binding inhibitory immunoglobulin, TBII. Second antibody is against thyroid peroxidase enzyme, which is involved in iodination and organification process. So if these antibodies are increased, it leads to decreased production of T3 and T4. These are also called as antimicrosomal antibodies. Third antibody is antibody against thyroglobulin, that is antithyroglobulin antibody. So these are the three important autoantibodies, and detection of these autoantibodies, it is used to detect the diseases of thyroid dysfunction. If the level of TSH receptor antibody is more than 1.75 international unit per liter, it indicates Graves' disease. So presence of thyroid stimulating hormone receptor antibody is diagnostic of Graves' disease, which is the most common cause of primary hyperthyroidism. Second, TPO antibody. It is indicative of Hashimoto's thyroiditis or autoimmune thyroid disease, and if it is more than 100 international unit per liter, it is indicative of Hashimoto's thyroiditis, which is the most common cause of primary hypothyroidism. Antithyroglobulin antibody more than 35 international unit per liter indicates autoimmune thyroiditis or Hashimoto's thyroiditis. And these antibodies can be detected with the help of techniques like ELISA, electrochemiluminescence immunoassays. Group 4 thyroid function tests are based on metabolic effects. For example, basal metabolic rate, serum cholesterol level. Basal metabolic rate is measured by using apparatus of Benedict and Roth, and the normal range is 24 to 26 kilocalorie per kg body weight per day. In case of hypothyroidism, BMR is decreased by 30 to 40%, and in case of hyperthyroidism, it is increased by 10 to 70%. Serum cholesterol level, the normal reference range is 150 to 200 mg per deciliter, and in case of hypothyroidism there is hypercholesterolemia, there is increased serum cholesterol level, while in case of hyperthyroidism cholesterol level is decreased. What is the diagnostic algorithm for detection of hyperthyroidism? If patient presents with the clinical features of hyperthyroidism, then first estimate TSH level and free T4 level. And by doing this, we can get three kinds of laboratory picture, where in the first case T4 is increased and TSH is decreased. This is indicative of primary hyperthyroidism, and most common cause of primary hyperthyroidism is Graves' disease. The other causes are toxic multinodular goiter, toxic adenoma, thyroid carcinoma, etc. Now to find out the exact cause, we have to estimate the antibody level, and the most common antibody, that is anti-thyroid stimulating hormone receptor antibody, that is TSH receptor antibody, it is increased in the Graves' disease. So if it is positive, it is the Graves' disease, and if it is negative, then thyroid uptake scan with the help of radioactive iodine and or technetium 99. The other etiologies like toxic multinodular goiter or toxic adenoma can be found out. In the another laboratory picture, if T4 level is normal and TSH is decreased, then it is the subclinical hyperthyroidism. Here we have to evaluate free T3 level, and if it is increased, it is indicative of T3 thyrotoxicosis. Then if both T4 and TSH, if both are increased, then it is the secondary hyperthyroidism. It can be due to the diseases of pituitary or hypothalamus, or there can be thyroid hormone resistance syndrome. Diagnostic algorithm for detection of hypothyroidism includes estimation of TSH and free T4 level, and if there is a decrease free T4 and increased TSH, the cause is primary. So it is the primary hypothyroidism. Most common cause is iodine deficiency and Hashimoto's thyroiditis. And we know that anti-thyroid peroxidase antibodies are elevated in Hashimoto's thyroiditis, which is autoimmune disease. So if it is positive, then it is indicative of Hashimoto's thyroiditis, and if it is negative, then we have to rule out other causes of primary hypothyroidism. Then if free T4 level is normal and TSH is increased, then it is subclinical or mild hypothyroidism. If both T4 and TSH level are decreased, it is called as secondary or central hypothyroidism involving pituitary gland and hypothalamus. Now coming to the clinical case discussion part of this presentation. So this is the case study 1. A 35-year-old female came to the OPD with complaints of nervousness, weakness, palpitation on exertion for past 8 months. Recently, she noticed excessive sweating and less bleeding during menstrual periods. She has maintained same weight but eating twice as much as she did 1 year ago. On physical examination, pulse was 120 per minute, blood pressure was 130 by 60 millimeters of mercury. Her eyes were prominent and she had lid retraction and lid lag. USG thyroid showed a diffuse goiter. On laboratory investigation, free T3 level was 4.5 picogram per ml, free T4 5.8 nanogram per deciliter, TSH is less than 0.01 milli international unit per liter. Normal reference ranges are also given here. Now the first question is mention the likely diagnosis and justify. So here the probable or likely diagnosis is primary hyperthyroidism. Why it is primary hyperthyroidism? We have to justify. So justification should include the key points in case scenario. This is the condition of hyperthyroidism because here the patient presents with various clinical features of hyperthyroidism, that is nervousness, weakness, palpitation, excessive sweating because of overactivity of sympathetic nervous system. There is oligomenorrhea, appetite is also increased, so these are indicative of hyperthyroidism. And what are the key points on examination and investigations which are suggestive of hyperthyroidism? There is tachycardia, pulse is 120 per minute, which is a characteristic feature of hyperthyroidism. The eyes are prominent, there is lead lag, so exophthalmos is there, and diffuse goiter is present. On laboratory investigation, we can see that free T4 level is increased, it is 5.8 nanogram per deciliter, and free T3 is also on the slightly higher side, and TSH is very much decreased here. So decreased TSH, increased T4 and T3, it is indicative of primary hyperthyroidism. So that's why the diagnosis is primary hyperthyroidism, and to justify this we have to write the key points in case scenario and key points on examination and investigation. The next question is, mention the various causes of above condition, and we know that the condition is primary hyperthyroidism. So what are the causes of hyperthyroidism? Graves' disease, that is the autoimmune disease, it is the most common cause. Then toxic multinodular goiter, toxic adenoma, thyroid carcinoma, these are the other causes of primary hyperthyroidism. Enumerate other thyroid function tests to confirm the cause of condition. We know that most common cause of primary hyperthyroidism is Graves' disease. So to confirm the diagnosis of Graves' disease, we have to estimate antibody level. So we have to go for anti-thyroid stimulating hormone receptor antibodies, and if it is positive, it indicates Graves' disease. Thyroid uptakes can also be done, and it will show autonomous or hot nodule. And if this antibody test is negative, then thyroid uptake scan will help to differentiate between toxic multinodular goiter and toxic adenoma. The next question is how the condition can be managed, means what are the various treatment options available for treating the Graves' disease. So beta blocker, that is propranolol, to elevate the various symptoms of nervousness, palpitation, anxiety. So the mechanism of action is, it is the non-specific beta blocker, and it also inhibits the peripheral conversion of T4 to T3. Methimazole, it inhibits the function of thyroid peroxidase, inhibit oxidation and organification of iodide, and in turn and also decrease the level of thyroid stimulating antibodies. So by giving these drugs like beta blocker, methimazole, the condition can be managed. Now let's see the second case where a 55-year-old female came to the OPD with complaints of nervousness, anxiety, palpitation on exertion for past 6 months. Recently, she noticed excessive sweating and intolerance to heat. So all these are the clinical features or symptoms of hyperthyroidism. Appetite was also increased compared to previous year, and on physical examination, there was tachycardia, pulse 92 per minute, BP 130/60, skin was warm, smooth, moist, but eyes were not prominent, means it may not be a Graves' disease. USG thyroid showed enlarged thyroid with 3 nodules, so it can be toxic multinodular goiter. So it is a primary hyperthyroidism. So let's see what laboratory picture says. Laboratory finding shows free T3 level is 4 picogram per ml, which is on the higher side but normal. Free T4 is 2.8 nanogram per dl, it is increased, and TSH is low here, that is 0.10 milli-international unit per liter. So what is the likely diagnosis here? It is the primary hyperthyroidism. Justification. The key points in case scenario are nervousness, anxiety, palpitation, excessive sweating, intolerance to heat, increased appetite. All these are the clinical features of hyperthyroidism. And key points on examination and investigation are tachycardia, smooth, warm, moist skin, enlarged thyroid with 3 nodules, and there is increased free T4 and decreased TSH. So this is indicative of primary hyperthyroidism. The second question is, enumerate the other TFTs to confirm the cause of condition. Now we know that this is primary hyperthyroidism, but now we want to confirm whether it is, what is the cause of this condition. So for that we need to estimate anti-TSH receptor antibody, and in this case if it is negative, then thyroid uptake scan will show 3 nodules. So this is the indicative of toxic multinodular goiter. In the previous case study, the eyes were proptotic and anti-TSH receptor antibody test was positive. So that was a Graves' disease, and this is toxic multinodular goiter. And the treatment for this condition is radioactive iodine or surgery. Now let's see this case study number 3, where a 45-year-old female came to the hospital with complaints of progressive weight gain of 6 kg in a year, fatigue, slow speech, dry skin, cold intolerance, constipation, slight memory loss. On physical examination, her BMI was 30, she was moderately obese, pulse 58 per minute, regular, blood pressure was 140 by 100 millimeters of mercury, thyroid gland was slightly enlarged, firm, non-nodular and non-tender. Laboratory finding shows free T3 level 3.2 picogram per ml, which is normal. FT4, that is free T4, is 0.6 nanogram per deciliter. It is decreased. TSH level is 21 milli-international unit per liter, means it is increased. Serum cholesterol level 320 milligram per deciliter, means there is hypercholesterolemia. TPO antibodies and anti-TG antibody level was increased. The first question is mention the likely diagnosis and justify. Now key points in the case scenario like weight gain, fatigue, slow speech, dry skin, cold intolerance, constipation, slight memory loss, all these are suggestive of clinical features of hypothyroidism. Now what are the key points on examination and investigations which are suggestive of hypothyroidism? Bradycardia, there is hypertension, enlarged, firm, non-tender, non-nodular goiter, there is raised cholesterol, free T4 level is decreased and TSH level is increased, means it is a primary hypothyroidism, and there is also raised thyroid peroxidase antibody, anti-TG antibody, which is suggestive of Hashimoto's thyroiditis. So this is the condition of primary hyperthyroidism and the cause is Hashimoto's thyroiditis. Other question is mention other causes of above clinical condition, means what are the other causes of primary hypothyroidism. So it can be due to iodine deficiency, post surgery, radioiodine therapy or external irradiation, and the drugs like lithium iodides, para-amino-salicylic acid, this can also cause primary hypothyroidism. Third question is explain the biochemical basis of hypercholesterolemia seen in this condition. So why there is increased cholesterol level in hypothyroidism? We know that in hypothyroidism there is decreased thyroid hormone level, decreased T4. And what is the function of thyroid hormones? Thyroid hormones activate the enzyme 7-alpha hydroxylase, which is involved in the catabolism of cholesterol, that is it converts cholesterol into bile acids, and that's why there is increased secretion of cholesterol in bile. So it helps to decrease the cholesterol level. It also induces the number of LDL receptors on the liver cell, and with the help of that there is rapid removal of LDL cholesterol from the circulation. So thyroid hormones will help to decrease the level of cholesterol. But in hypothyroidism there is decreased thyroid hormone level, so that's why these functions are inhibited, and that's why decreased thyroid level, that is hypothyroidism, it is associated with hypercholesterolemia. What is the treatment of hypothyroidism? This patient should be given thyroxine, that is the levothyroxine. So in today's video we have seen various thyroid function tests along with the clinical cases, and I hope this video lecture series on thyroid gland will be helpful to you. Thank you for watching and happy learning.